Well, greetings everyone, and hope you've been having a decent weekend. I wanted to run by everybody the idea for a possible new curriculum. It's not a big deal, but a bunch of people have emailed about increasing the EKG training, and which is music to my ears. And so one of the things I was thinking about was maybe just once a week sending out a little video clip of EKG case, one or two cases, no more than 5 or 10 minutes per week. And I figured that with the little additional 5 or 10 minutes of EKG training every week, it could really bump up the EKG knowledge of the folks in our program. So email me and let me know what you think of this curriculum. If you like it, we'll continue with it. If I don't get much response from people, then we'll just forget about it, and we'll see how it goes. So again, just 1 or 2 cases per week. Before I go any further, though, I have to acknowledge the importance of this weekend. It is 9/11 weekend, so 10 years ago was the 9/11, and I'm sure everybody out there listening has some special memory of what they were doing during 9/11, and so I think it's appropriate to acknowledge the people that lost their lives and how this has influenced all of our lives. Okay, we'll go ahead and get started. This is a 73-year-old man who presented to the emergency department at university complaining of some palpitations. And I'm not going to get into details of his history. Overall, he was otherwise pretty well. He just had some palpitations. And so a 12-lead EKG was obtained, and it shows a narrow, regular tachycardia. Now, I don't want to get too much into the details of the conduction system abnormality here. The patient has an RS-R prime pattern in V1, suggesting a right bundle branch block pattern, but the QRS, if you measure it out, is just a little bit less than 120 milliseconds, so this would be considered an incomplete right bundle branch block pattern. And if any of you were thinking ventricular tachycardia, I think that's great, but truly to be ventricular tachycardia, it ought to be at least 120 milliseconds, and this is just a little bit too narrow to be considered VTAC, but it's always good to think VTAC whenever you think something might be wide. So let's call it a day in terms of talking about the conduction abnormality there. Let's just call it a narrow regular tachycardia. Sorry. And so we've talked about this before in conference. A narrow regular tachycardia has one of 3 possibilities, one of 3 etiologies. Sinus tachycardia by far is the most common. And then we've got SVT, and then we've got atrial flutter with 2-to-1 conduction. Simple enough. If you remember those 3 things in the differential, for everybody who's got a narrow regular tachycardia, you're going to end up nailing 90% or more of the diagnoses when you've got a narrow regular tachycardia. And then how do you figure out the difference between those 3? You simply ask, what's the atrium doing? Are there P waves, yes or no? Is there flutter present? Is there 1 P for every QRS like you'd see with sinus tachycardia and so on? So you simply need to ask, what the heck is the atrium doing? And if you look carefully here, well, it's kind of tough. I'm not sure I see regular, clear PQRS, PQRS, PQRS type of pattern that the way you would expect to see with sinus tachycardia. Although the physicians here actually commented, as I recall in the report, that there was P waves in V3, and so this was actually diagnosed as sinus tachycardia, PQRS, 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 and so on. So this patient was diagnosed with sinus tachycardia. Some of you may be looking at this and say, well, I don't know that those are P waves. Maybe those are T waves. Maybe this is actually SVT. And then some of you may be, for another reason, be thinking about atrial flutter. So what actually happened with this patient? The patient was diagnosed as sinus tachycardia and got 1 liter of normal saline with the presumption that he's dehydrated. That'll bring the heart rate down. Well, 1 liter didn't do it. So he got a second liter didn't do it. Then he got a 3rd liter. And after 3 liters of normal saline, after 3 hours in the emergency department, with the heart rate tacking away at 135, people finally took a closer look at the 12-lead EKG and realized that this guy had atrial flutter the entire time. And fortunately, he didn't decompensate, but it certainly isn't nice for a 73-year-old guy to run a heart rate of 135 unnecessarily for a number of hours. And after the diagnosis was made, they finally treated him with some, I think, beta blockers or calcium channel blockers, either way, and got his heart rate down. So I want to spend a few minutes talking about atrial flutter because it clearly is the most misdiagnosed tachydysrhythmia that's out there. There's actually literature supporting that statement, so it's not just me making that up. We'll start out with the very important pearl. Anytime you see a ventricular rate of 150 plus or minus 20, that patient has flutter until proven otherwise. And how do you prove otherwise? You have to be really paranoid. You have to look in all 12 leads. And if you have a rhythm strip, then look at all 13 leads. Look at the rhythm strip also. Look really, really carefully for flutter waves. Don't rule out flutter until you have taken a really, really paranoid look at every single lead that you see, because sometimes those flutter waves are hiding in just one lead or just in two leads. And if you don't look carefully, you're going to end up missing flutter and mistakenly calling it sinus tachycardia, which is probably the most common misdiagnosis, or SVT or something else. So be really paranoid and look for flutter. So let me take you through a handful of cases of misdiagnosed flutter and some of the consequences of that misdiagnosis. So take a look at this. This is a patient who had atrial flutter, misdiagnosed as sinus tachycardia. And I think the reason that this patient was misdiagnosed as sinus tach was because the physicians looked in V3 and saw what looks like PQRS, up here in V4 also. But wait a second, the heart rate's 150 plus or minus 20. That means you've got to look in all 13 leads. You've got the 12 EKG leads and you've got the rhythm strip. 13 leads. Be paranoid. Look carefully. And with the healthy degree of paranoia, you will see flutter. Take a look in leads 1 and 2. There's an upright P wave. There's another one. There's another one. There's another one. If you're thinking that's artifact, just map it out. Get your calipers, map it out. Artifact doesn't map out. Those are flutter waves. That's atrial beats. You see it in lead 2 also. P wave, P wave, P wave, P wave, and so on. This is atrial flutter with 2-to-1 conduction. Misdiagnosed as sinus tachycardia because people only looked at a couple of leads. And also the machine got it wrong also. Machines are not that good at making the diagnosis of flutter. It's no better than you, so you can't rely on the machine. This patient sat in the emergency department for 4 hours getting IV fluids for presumed dehydration, and the heart rate just kept going at 150 before somebody finally realized that this was flutter, right? Sinus tachycardia should not go for 4 hours at the same exact heart rate. So that's another tip off there. It should be changing somewhat, especially with all the IV fluids. Here's a patient with flutter misdiagnosed as SVT. And again, the computer got this wrong and called it simply SVT because it didn't clearly see P waves. So the physicians gave this patient some adenosine. Now, adenosine is not the worst thing in the world. Adenosine slowed the ventricular rate. It doesn't affect the atrial rate, though. It slowed the ventricular rate. So as the ventricular rate slowed down, the flutter waves became more obvious. And then they made the diagnosis of flutter, and then they treated the patient appropriately. But you know what? That probably wasn't even necessary, because if they said, you know what, the heart rate's 150, we got to be paranoid, look in all 13 leads, they would have looked down here at lead 3 and seen P wave, P, P, P. That's atrial flutter. You look up here, and it's a little bit more subtle up here. You know, you look in V2, there's inverted P waves. Our eyes are not that good at picking up inverted P waves, though. But if you look everywhere, oftentimes you'll see some upright P waves, and those are much more obvious. Here's another one. All right, this patient was misdiagnosed as sinus tachycardia, and the patient sat in the emergency department for several hours with the misdiagnosis before people finally made the proper EKG diagnosis. It was seen by consultants also who thought this was sinus tachycardia. If you look up here in V1, and I oftentimes refer to V1 as the best lead to look for P waves, not 100%, but in many cases, V1 will show you P waves when other leads lead you astray. Take a look up here. There's a little spike right there, and another spike right there, there, and so on. Those are flutter waves. They map out at a rate of about 300. Heart rate's 150, ventricular rate that is, 150 plus or minus 20. You've got to be paranoid. And down here in the inferior leads, you actually see inverted P waves. A lot of people don't see those because I think our eyes are not well trained at picking up inverted P waves because we're so accustomed to looking for upright P waves. We don't see things that are upside down. Here's a little thing that I like to show people sometimes. Most people look at this and say, well, this is the Mona Lisa, right? Well, remember, when things are upside down, we don't really see them that well. Let me show you, when I put this right side up, what you're looking at right now. This is what I just showed you. This is not the Mona Lisa. She's very unhappy with you for calling this a Mona Lisa. This is actually her grumpy sister. No, just kidding there, but of course. But you take the smile and turn it upside down, and people don't really notice that when the overall image is upside down. I don't know. It's just kind of a silly way of me trying to demonstrate that our eyes don't see things well when they're upside down. And I think the same thing is true for P waves. When P waves are upside down, as they are down here, our eyes often miss them. So one of the other tricks that I like to tell people to do is, if you don't clearly see flutter, before you abandon the diagnosis of flutter, take that 12-lead EKG and flip it upside down. And when you flip it upside down, suddenly the P waves become upright, and magically they become much more apparent. So before you abandon the diagnosis of flutter, just take that 12-lead and flip it upside down. And sometimes the P waves that you didn't see because they were inverted, now your eyes magically will start to see. Here's another example. In fact, let me go back to the original case, that A flutter with the ventricular rate of 135, misdiagnosed as sinus tachycardia. If we take this 12-lead EKG, right, and we flip it upside down, now, my gosh, it's really easy to see that flutter, right? P wave, P wave, P wave, P wave. But when it's like this, our eyes just don't see it as well. You flip it over. Sorry if anyone out there is getting vertigo, but you flip it over, and now it's a lot easier to see the P waves because now they are upright. Here's another example. This patient was misdiagnosed as SVT. And, you look down here at the inferior leads, and it's just a whole bunch of junk. Now, this is a tougher one, but you know what? Before you abandon the diagnosis of flutter, take that 12-lead, flip it upside down, and now the flutter suddenly shows up. P wave, P, 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 and so on. And this is flutter with 2-to-1 conduction once again, and you didn't see it when the P waves were inverted in the original EKG. All right, another example. This is from BWMC. One of our former residents who's a graduate now working over at BWMC sent this to me. The EKG machine called this SVT because the machine didn't see P waves. He didn't see P waves either, but he had learned this trick. He took the 12-lead, he flipped it upside down, and now the P waves magically appear. You get your calipers, you map this out, and these blips map out to a perfect heart rate of about 300 or so. They map out nice and regularly. This is flutter with 2-to-1 conduction. Yet another example. Now this case was a patient over in radiation oncology who was tacking away. The patient was getting chemotherapy, had some vomiting, and so the radiation oncology folks, they sent the patient over to the emergency department saying the patient's dehydrated, tachycardic, needs some IV fluids. So the patient came over, got a 12-lead EKG, and this is diagnosed as sinus tachycardia. The patient got 1 liter of IV fluids, heart rate remained 150. 2 liters, 3, 4, 5 liters of normal saline. The patient's been in the emergency department for 5 hours, gone through change of shift, and people have kind of forgotten about him. The sign out was the patient's dehydrated, getting some IV fluids, and the team upstairs won't take them until they're not tachycardic anymore. That's a good thing, because the patient ended up getting heart failure from all the IV fluids that were given, because everyone thought it was sinus tachycardia and dehydration. In reality, this is just flutter. The patient needed some IV beta blockers or calcium channel blockers. So how do you know? Well, take a look in V1, our money lead. There's a P wave, P, P, P. This is flutter. And down here in the inferior leads, there are inverted P waves, but they're a little tough to see. So let's take that 12 lead and flip it upside down. And now, my gosh, look how easy that flutter is to see now that the P waves are upright. And all it took was a little flip. Flip that 12 lead upside down. The patient ended up going to the CCU because of congestive heart failure that was iatrogenic. The other trick that you can do is, the other trick that you can do is, we're all accustomed to seeing the 12 lead run at 25 millimeters per second. You can actually speed it up. So instead of running that 12 lead at 25, run it at 50 millimeters per second. That stretches everything out, and when things get stretched out, that flutter oftentimes becomes more obvious. The arrows are pointing at the flutter waves. And that's what I like to refer to as the Bob Vila or Ken Butler trick, because Ken loves to do that. And I think that's a nice, very effective way of doing it also. Sometimes people say, well, how about just give him some adenosine and that'll do it? That's kind of a cruel thing to do. I don't know if you've ever had adenosine before, but before you start haphazardly giving adenosine to people, just because you're too lazy to flip a 12-lead EKG, why don't you take some adenosine yourself and see how it feels? So I wouldn't give adenosine to somebody as a diagnostic challenge until you've tried slowing that 12-lead, or rather speeding up the EKG, or just doing the little flip trick. And so a couple of simple things you can use to diagnose flutter. So again, just to recap, every EKG with a rate of 150 plus or minus 20 is flutter until proven otherwise. Look in all 12 leads. If you have a rhythm strip, you've got a 13th lead. Look in all 13 leads carefully for flutter. Flip the 12 lead upside down. Sometimes the flutter becomes more obvious. Even try speeding up the EKG, and sometimes the flutter will become more obvious there as well. Okay? And so that's it. That's it for this flutter series of EKGs. And again, send me some emails and let me know what you think of these little weekly video things. If a lot of people, I should say, are interested in me continuing to do this, I'd be happy to continue doing this. If people are not that interested, then I'll do something else with the time. All right. So hope this was helpful either way. Thanks a lot.